All right, so again, good morning, Dr. Sabri. I hope you're doing well. It's a pleasure to have you here today with us, and we can't wait to learn more about IR from you. So, to start off, can you please introduce yourself and give us a background of IR?
Yeah, so my name is Saher Sabri. I'm currently interventional radiologist at Georgetown University Hospital in Washington, D.C., and I'm chief of interventional radiology for a large health systems called MedStar Health System. And also part of it is the university. I'm also the president-elect for Society of Interventional Radiology. I started my journey as a what we called international medical graduate. So I did medical school in University of Jordan, and then I did my residency in the U.S., University of Iowa, then did fellowship University of Virginia, and worked there for some time, and then moved to Georgetown. So started in the region, and then moved to the U.S. for training, and then
Mhm.
interventional radiology was of interest to me. I didn't know much about it as a student. Of course, you didn't get a lot of exposure to radiology in general, let alone interventional radiology. At that time, it was a while back. Things are changing now, and there's more exposure to interventional radiology in earlier in medical school nowadays, so people are aware of this specialty. So I kind of learned about it some, but then as during my residency, when it was definitely more introduced to it through some mentors, and then got involved in research in interventional radiology, and then from that on, took on as a specialty. And I think as image guided interventions is something that is very exciting. The aspect that I like the most about it is you can combine the procedural aspect and the image-guided interventions with the clinical aspect of it, that seeing the patient before and after the procedure, and following them in a longitudinal fashion that you can see them, is something that is of interest to me. I think that's the best way to practice interventional radiology. So combining my clinical interests with the procedural interest, and of course, imaging and fascination with new technology, made it a good fit for me as a specialty. And that's when I advise students about their interest. And this is something I bring up a lot, that, it really combines, several aspects that are important. It's procedures, imaging, and clinical care all in one. So it's a good win-win-win.
Yeah, it's an amazing specialty, and we also had the pleasure to talk with Dr. Arabi about it the other day. And yeah, now to start off with the first question of this interview, can you tell us about the scope of interventional radiology in the United States?
So, the interventional, I mean, it's similar to the United States in terms of what interventional radiologists do. It's um, similar across the world in general, but definitely each region has its own unique setup of situations that allow them to practice in certain fields more than other, certain disease states or certain procedures. Um, so generally speaking, we do a lot of vascular and vascular interventions and non-vascular interventions, and the range is very, very wide. As you know, interventional radiology is not a disease state, which is sometimes makes it harder to explain to the public, because it's easier to say, I'm the bone doctor, I'm the kidney doctor, and so on and so forth. When you say interventional radiologist, I'm the old organ systems doctor, but I do a way of treatment. So that is always a harder thing to explain to the public. But I think within the health system, the everyone is realizing, recognizing the value that interventional radiologists bring. So yeah, so that ranges from as simple procedures that are needed for the hospital, such as getting, whether it's venous access, whether it's port for chemotherapy, whether it's even biopsies and things like this, to providing more complex procedures, such as embolization for bleeding. And embolization is a word you're going to hear a lot. Embolization meaning, using endovascular tools to block a bleeding artery, or to block an arterial or venous disease, or block a vessel for one reason or another. So So embolization is used in, whether it's, for acute bleeding. It can also be used to treat tumors. It can also to treat benign conditions such as, fibroids and prostates and knee osteoarthritis and such. So it's, again, a methodology of treatment. So the scope is very wide. And, the type of practice is also wide. So you have people who work in large hospitals, whether it's academic centers or that have teaching, or just a large hospital that is a big referral center, and usually do higher end cases, and whether it's portal hypertension, whether it's oncology, some of these things I mentioned, to some who practice in an outpatient lab, which is a self-standing facility that does only interventional radiology. This is a very popular thing that's becoming more and more frequent. Also in the what's called the private practice, where there's a group of interventional radiologists and diagnostic radiologists who contract with the hospital and then practice that way. So these are several ways that people can practice, and the scope and the breadth of procedure is very, very wide. In a small hospital that doesn't have a lot of patients, may end up being mostly minor procedures, some of the biopsies and drainages and central line, to a very complex, recanalization of occluded veins and occluded arteries and such. So it's a wide scope practice, and people choose how they want to practice, and allows you a lot of abilities. And the majority decide to practice, heavily in the interventional radiology space. Some decide to do some diagnostic as part of their practice, so they do a hybrid practice of diagnostic and interventional radiology. So these are all, that's a scope of what people do.
All right. And for students who are interested in the field, what are the main pathways to getting into IR in the US?
Yeah, so the main things are, to get into the training in the US, depending where your training is starting. All right, so the main pathways currently are a direct match through the integrated IR residency match, which is a match directly from medical school. And that's a general match that everyone goes through for all specialties. Same for diagnostic radiology and such. So that's a one main path. The second path is to match into diagnostic radiology and then do a training. It's called independent residency after completing the diagnostic radiology training. So you finish your training in diagnostic radiology, you get boarded in diagnostic radiology. Sorry, so you go into diagnostic radiology, you finish your diagnostic radiology board, and then you do a 2-year fellowship. It's called independent residency. It's basically another name for a fellowship, and that 2 years basically completes your training. In now you're double boarded interventional radiology and diagnostic radiology. Similarly, at the current time, if you do the integrated residency, which is 6 years, you also it's called you finish with what's called an IRDR certificate, interventional radiology diagnostic radiology certificate. So this is a 6-year pathway, includes an internship, and then 5 years combined IR and DR. The other pathway is an internship, followed by 4 years of DR, and then 2 years of IR. There is currently within the DR years, if you do a focus time in your training, mostly in the last year of diagnostic radiology training, that you end up doing at least a certain number of months of IR, usually 11 months or so, and you do a certain number of procedures, a minimum of 500, you can qualify to only do 1 year of independent residency rather than 2 years. This way you finish in 6 years. But so that's called ESIR, early specialization IR. But regardless, you have to go through your diagnostic radiology training, finish, sit for the boards, and then go forward with the next steps. So these are the two main pathways. Now, for international graduates, of course, the best pathways to go through the match into the integrated or into diagnostic radiology, and then go from there. So that is the pathway, to go through. Of course, last year's match, I think 5% of the people, there's 209 basically candidates matched into. into the integrated residency, and 5% of them were IMGs. So 5% out of 209. The number of applicants last year was around, got the exact number, but somewhere in around 570 to 580, something like this, applicants for 209 positions. So that's just to get a sense of it. And then around a third of the applicants were IMGs, international graduates. So, the percentages are harder, of course, as you all know, because it's a very competitive specialty. So that is the setup. Now, there's another pathway, which is if you finish your diagnostic radiology, if you have a diagnostic radiology training at internationally, then you can come and do just do the independent residency only. So that is a potential that can be done. But you cannot sit for the boards because the boards currently are an IRDR combined board. There's no separate board for just IR only, like in the past. So basically, you can come and do training, but not sit for the board. To be able to be certified, and I'm going into a lot of details, so if I'm going into a lot of details, you can stop me at any point. But if you want to get boarded, there's what's called an alternate pathway, which is to do, so once you come in and do 2 years of training, if you do 3 more years of training or practice in the States, in a hospital that has a training program, after these 5 years, you can sit for the IRDR boards. So there's that option. But you should have a completed a residency training abroad, a diagnostic radiology residency training abroad, and have a certificate that you completion, and then you can apply to go through the independent match, and then go to do 2 years. Again, you can do 2 years, go back to your home country. I mean, that is a very valid option, but you're not going to be boarded. You have a certificate of completion of training, but you cannot sit for the American board. To get the American board, in which is a combined IRDR board, you have to do to finish 5 years of training, which means to do another fellowship and things like this, in neuro or some other area to be able to sit for that.
Now, a small question here. The USI residency programs are known to be non-IMG friendly. What's your best advice for us to distinguish ourselves from the USMG or the USIMG?
Yeah, I don't know about you saying not friendly. I would just be careful with that, because I think, everyone is welcome. And then I think it's not a matter of not being friendly to foreign graduates. It's just about the competitiveness of the market. There are more than 100 of US medical grads who graduated from medical school who did rotations in IR who do not match. And there's always a pressure, of, it's like, why not? I mean, somebody who does well and does good grades, and then there's not enough spots for everything. So it's understandable why it's hard, when it's that competitive, when a lot of the US medical grads, cannot get in. So that's just something this is the nature of it, and that is not unique to interventional radiology. It's also for many other surgical subspecialties. That being said, there's 5% who make it. So what distinguishes the 5%? I mean, I think for the most part, the things that it can be done, which are not easy to do, is show interest early in the specialty, understanding the specialty, which is all what you're all doing. So that's number one. Number two is to do rotations in the US, which is hard to do, I know, because there's a lot of hurdles, whether it's a visa issue, whether it's a availability of spots, because that's a problem that we have, which is a lot of the institutions are not taking people to do, not taking medical students to do rotations, because of a lot of agreements and issues that, they take from only certain affiliated schools, but not, which excludes the majority of the schools in the region. So that is an issue with securing a rotation. Observership is okay, but it's not as good as a full clinical rotation to get a recommendation letter. The other the other thing is to do a research in IR, of course, having any research in the field. And you know, for example, at your institution, you have a lot of interventional radiologists who publish work, editor of journals in the region like AJIR and others. You can of course work on publish and work on, and because the level of IR that is, for example, you're in Saudi Arabia, the level of IR that is delivered in Saudi Arabia is no less than the majority of practices in the US. Right, just keep that in mind, and you need to know this, that for example, Haras, Faisal, and several other places, the level of IR that is done, the complexity of cases, the care, and all the stuff is not much less than a large, part of practices in the U.S. and Europe, for that matter. So this is something I think we should all be proud of. So you can work on, getting your skills up, doing research, and publish, and all these things to distinguish yourself. So these are some things you can do. Of course, as I said, there's 5% on the diagnostic side, but on the interventional side, on the diagnostic side, it's ranges between 10 and 15%. So there's more chance, and the numbers are higher. We're talking about 200 versus 2,000. So there's a lot more positions, and if you just look at the sheer number, there's a lot more. So going into diagnostic radiology, then going and do that 2-year independent pathway, whether it's a 1 year or 2-year independent pathway, is a very good option. And that's what when I speak with a lot of the mentees who are international, graduates, I just tell them that, the easiest path at this point is to go through diagnostic radiology and then go from there. That's why the independent pathway is important, because of that, and then to do the diagnostic radiology in the US. And so I think it is a good option in going out there and doing trying to kind of find a research fellowship and things like this after medical school is also a very good point, but it's really hard to find these. It's really hard to connect with somebody, and there's not a lot of funding. If somebody has funding source, that'd be great. If somebody's self-funded, that's great, but trying to look for a funded position and that needs visa sponsorship are really hard. But if somebody does not need visa sponsorship and they have funding to do a year of research, for example, that could be helpful. But again, that is unfortunately allows people with means to be ahead of people who don't have that mean or that privilege. So that is also an unfair way, but that's the reality.
Mm-hmm. Now, you mentioned research. So, as an international medical student that's interested in IR, how important is research for residency, and what kind of projects tend to stand out the most when applying for IR in the US?
So I mean, as I said, in general, you have to differentiate yourself. I mean, not everyone is going to be a researcher when they go out and practice. So, it just it's not something that is required to be a good doctor out there to be a researcher. That being said, you have to differentiate yourself to show interest in the field, to show that you're interested in the scholarly work. So becomes an important thing for the application, and especially when you're an IMG. Excuse me, you have to just differentiate yourself from other applicants. It's the nature of it. So that's why, yes, it is important to be able to do so. So I would definitely encourage anybody to be involved in research. And I think a research could be a case report on something, but a case series is better than a case report. A meta-analysis is better, so, and then and so forth. And the more you do a review article of a topic and then publishing it is also very good. That shows initiative, shows a lot of time and effort. Writing a case report is easy to do. Collecting 10 cases of something, write about them is good work and all this stuff. But doing a review article, that's a lot of work. So I think that shows also initiative on a topic. So there's a lot of avenues to do it. I think AJIR is an avenue to publish, and it's easier to publish than some other. But there's a lot of other journals. Also, have to be aware of predatory journals that it's paid to publish and all this stuff. You have to be careful with that, and people know this stuff and can recognize it. So have to make sure that it's respected journals. So that's important. Again, if you're applying to diagnostic radiology, any diagnostic radiology research is also good because you're applying to diagnostic radiology as well. So that is fine. So that is a path that you can work on. Yes, research is important.
All right, thank you. And how would you describe the current practices and trends in IR across the country? I think you mentioned it before, but just to mention again, what are the current,
The different types of practices, you mean? Yeah.
yeah, the
Yeah, I
practices
mean,
and trends across the country?
yeah, I mean, I think it's yeah, I mean, we have around 2,500 to 3,000 interventional radiologists in the US, and they are again the range of who does high percentage of their practice IR versus not. They are another 2,000 or more who practice some IR, but the majority of their practice is diagnostic radiology. The one who practice more than half their time in IR, they're just either in, the majority, more than 70% are in private practice, and the third or so are in academics. So the majority are in what's called private practice. They're not associated with a university, so to speak, or training program. So yeah, so a lot of them are in traditional, what's called the diagnostic radiology groups, where groups of physicians who have they self-govern, and they just have diagnostic radiologists and interventional radiologists, and they contract with the hospitals. That's kind of very, very common. It can be hospital employed, a health system that employs the doctors directly. Whether it's they hire a group of interventional radiology and diagnostic radiology, or hire a group of interventional radiologists only. And then contract with the diagnostic radiology group. So there's all these variations in practice that happen. And as I said, there's also it's called the outpatient lab or outpatient IR practice, which is a common thing that's growing significantly. A lot of people want to do high-end IR. They don't want to deal with the hospital. They want to take calls. So that is a very attractive thing for a lot of people. And it's growing. And, it's also growing in Saudi and other areas in the Arab world as well. So these are, of course, some of the, practice patterns that we're seeing. There's some little bit of differentiating. There's more group that are going towards 90%, 100% IR. And some group are doing less and less and doing a little more diagnostic and some lot IR. So there's all these differentiation that's happening now in the practice. But and the last thing I want to mention is there are now some interventional radiology practices that are separating from diagnostic radiology within the health system. So becomes an interventional radiology department with a chair, interventional radiology chair. So that is also a common trend that is happening, because there's a realization of the difference between the two. That being said, the training pathway is still connected, and there's a lot of ways. I was just talking earlier how you wanted to go through diagnostic radiology to get to interventional for a lot of people. So it is an evolving process. There's more interest for a lot of ways to gain a little more separation because they're different. Some others see the value in staying under the radiology umbrella, but it's a political discussion. But just generally speaking, that's what's going on with the kind of overall landscape.
All right, got it. Now for the remaining questions, I'll have my colleague Hanan. Hanan, are you here?
Yes,
Yeah.
so I'll be taking it on from here. So doctor, many students are curious about exposure to IR in general. So what's the best way to get into IR electives or observerships in the US?
Yeah, that's the hardest one. It's not an easy thing. I get a lot of emails all the time about this, almost weekly, and several of my colleagues. The medical schools, they have a lot of restrictions of the students they can accept internationally who they don't have a certain affiliations with. So they have with few, medical schools across the world that they have affiliation with. Otherwise, it's within the US and Canada only. So, yeah, that is an issue. There are few here and there that allow for rotations and with like a paid rotation, which also is, I feel it's somewhat unfair because it just allows people with means to have more access than others who don't. But yeah, rotations are harder. They are, especially if you're from a foreign school. Like if you finish training, sometimes it's easier because you can come and do shadowing. Shadowing is usually for medical students is also a lot of places is an issue because there's some responsibility and such. But if you're not a student and you're done, to come and shadow and watch is fine, but it's called observership or shadowing. doesn't give you the same as actually doing the rotation and seeing patients and rounding on them and be scrubbing and procedures and such. So it is a very hard thing to do. I don't have a good answer for you, unfortunately. It's been the biggest hurdle. I did it when I was a medical student in University of Jordan. I just went into rotations in the US. It was a much easier process at the time. Now it's an extremely hard process to do. And unfortunately, I do not have an answer how to create a better setup.
So doctor, do you have any institutes or hospitals on the top of your head that could accept foreign students?
No, I do not. And I know that is something that I always asked about. And sometimes I just heard from somebody that gave a name and that being, no, we no longer do it. Don't give our name again and all this stuff. So I really do not. And I don't think I'm in an authority to share for other organizations. So unfortunately, I do not. And I think I recommend for you as a group to try to, if you hear of somebody who successfully get that, to kind of collate the data and all that stuff. Crowdsourcing always works. So rumors, fly, quickly. So it's good for you to collect a, set. But the problem that, program will be bombarded by a lot of people from around the world because there's not a lot of them, but it is an issue. And I unfortunately cannot give you names not because I don't want to, because I don't know, to be honest with you.
Yeah, no worries. Thank you, doctor. Next question is, looking ahead, where do you see interventional radiology going in the next 5 to 10 years?
Yeah, I think we're gonna see more global adoption. I think it's a mature practice in a lot of parts in the world. So, for example, in the US, I think more clinical work as we go. We may lose people to do more diagnostic radiology because they just see that as a choice of career the way it is now. You can do remote work and all that stuff. So that's going to happen. So there's going to be some attrition from that perspective. At the same time, you're going to get more people who want to do more heavy clinical work, and people are just going to identify themselves one way or another. It's going to be that evolution. New technologies always come, new procedures. We do a lot of procedures. There's going to be a lot more outpatient works. Outpatient labs going to grow more and more. For sure, there could be some more separation of IR from DR in a lot of hospitals. All going to happen on local level. It's not going to happen at the institution level. It's not going to be like we no longer talk to, that's not going to happen because there's a training pathway is the same. So it's all going to happen organically at local hospitals and local environment to see if its situation is fine or it's better care an organization to have a separate setup. Globally, what I think the growth is going to be, because we have a lot of areas around the world that do not have robust IR practice, and a lot of people getting trained and going back to their home countries, which is great to see. And I think that's what we need to see more of, is growing IR practice across the globe. And we already see it, where we are now compared to where 10 years ago. A lot of countries has evolved. And, I think an organization like PAIRS, for example, is helping spread the word about IR, educate people. We get now people come to PAIRS from all around the world, and a lot of places that we didn't think that they have interventional radiologists. And then this person comes in, get trained, and they go back and then train others, and so on and so forth. So I think that has been a great success to help set up these different connections. So growth globally is what I hope to see more of. I think it's going to happen. I hope to see more of. Don't ask me about AI in interventional radiology, because AI is going to fix everything. Everything's going to be AI. It's going to be changing the way we practice, maybe in 50 years, not in 10 years. In diagnostic radiology, maybe, but not much in IR. I think will be some applications for sure and all that stuff, but it's not going to drastically change what we do on a day-to-day basis. It's going to change how you apply, because nobody writes a statement. They're going to use AI write it for you. But just be careful with that. Put your personal touch. Don't let a chatbot write all your stuff. Just make sure whenever you apply, just use your own personal touch as much as possible. Get help from other tools is fine. Just make sure your personal touch shows.
Yeah, of course, we'll do, inshallah. So next question. We already talked about research, but can you give us some specific ways for students outside the US to start being involved and contributing into research in the US?
Yeah, I mean, involved in research in the US is going to be harder because you're reaching out to mentor in the US. It's like, what project do you have? They don't know you. Even if they meet you, it's like, I'm going to give you a data set. They should give you a data set of patients because of it's called the HIPAA rule, which is patient protection, information protection rule. So it's hard. I mean, you can just do it like a review article with somebody or, something, that does not include patient data. That could happen if somebody has the time, but they also have a lot of students they have there that they want projects and they just don't have enough bandwidth to work with everybody. So that's always an issue. But yeah, working with local mentors is the best option. I know they're also overworked. They also have a lot of projects and such, but teaming up with 2 or 3 of you to work on a project is also something. It doesn't have to be I'm just the only one. So, but yeah, review articles are good because that is intellectual contribution, but it does not need you to have a patient data, even if it's a procedure you've never seen. You can still study and read about it, and then and do some of these things and such. So that would be my recommendation. In terms of that, of course, if you see a good case, an interesting case, and discuss it and see if you can submit it as a case report, that's something. But yeah, I mean, that will be that's the other part. Yeah, to do a longer research in the US, I think will require time after medical school to potentially travel to somebody and be there, but you have to have self-funding and an ability to travel, not needing a visa requirement. And that is, again, available to some. It's not helpful to many who don't have that, but if you have these means, it could work. But again, you need somebody who's willing to have the time and effort to have somebody around. And again, everyone is busy. Everyone has their own students and residents and all that stuff to deal with. So it's not easy, but sometimes it works.
Okay, so final question is, what is some advice you would give to medical students who are passionate about IR and want to start building their path early on?
Yeah, so I mean, I think like everything else, I mean, don't worry too much about the process. Everybody gets so hung up on the applications, this and that, and how do I do? And then you just forget the most important aspect of it is you want to be a good doctor. Like you want to excel in medical school. You want to tackle every rotation, like you want to be the best student they've ever seen. That is your goal for every rotation, regardless if you care about that thing, if you want to ever do OB or if you want to do pediatrics, if you ever want to do surgery, regardless, they should see you as the best student they've ever seen, right? Regardless what your interest is. Don't ignore any rotation because that's not a specialty I'm going to. All right. And then don't keep so focused on just the application process and all of a sudden you're just not becoming a good student or a good doctor, right? Because you need to be a good doctor. You need to care about your patients, connect with your patients, learn from your patients, and spend the time and effort. If things will take care of themselves, eventually you'll find your path. But if you missed steps in the way in your foundation to be a good doctor, you'll regret it in the future, right? And even if you secure a spot and you have some deficiencies, it will show and you may not be successful. So tackling every task you have with absolute, sincerity and then full effort is important. Treating your patients with empathy and care and caring about every single interaction you have with your patient is extremely important. That's what's going to make you a good doctor, not just the fact that you did research or published this or that. And these things show, and people who are sincere and care and take care of patients, they show. Even if you end up making it into a residency here or there, from the internship, they can tell you're not going to be good, and you may not be successful. So the last thing you want to do, work through all this stuff and you're not doing the hard work. So to be a good doctor that's my number one advice. I know it sounds very cliche or something, but I cannot tell you the number of times I see people skip steps and focus on the win rather than actually going through it the right way. So that to me is probably the most important advice. But beyond that, I think being involved in these interest groups like this is important. Being exposed to, going to meetings, going to regional meetings, I think is very important. I think we really need to make sure that, more people know about the specialty. I think thinking about creating more rotations out of medical school, working on that process to have, more exposure is also good. And if you help in that process, if you're a senior student, you help teach junior students about it. That's also an important thing you can put in your CV and all that stuff, and you also contribute. So these are all steps that I think are very helpful. And then yeah, I mean, go through, get your application together and see what you can do, and then go through the match. And if it doesn't work, just think about the path of doing diagnostic radiology in the region, and then going to do the 2-year independence later on, because that is I can tell you, it's the last thing I'm going to say on this. There are a lot more independent spots, and then IMGs can easily, be more competitive in the independent residency than in the integrated residency. Just because by that time you lose a lot of the pool. There is funding for independent spots. There's not enough applicants. So believe it or not, it's kind of the opposite. So doing a diagnostic radiology in your home country and then applying for independent residency is a much easier path to do it. Now, the issue is the board certification, as I mentioned before, but the competition for that is less. Now, of course, you need to be ECGME certified. You have to do step 1, 2, and 3 and all the stuff before applying. So that is an important thing. But yeah, I mean, I just learned of a foreign graduate or international medical graduate, was interacting with them recently, managed to get into a small program, diagnostic radiology, and end up later switching to a much bigger program. And they're just very happy. It just, their path was long, but they just did it. They got the foot in the door. They were just exceptional because everyone realizes how good they are and end up finding a way to transfer to another bigger program. And now they're going to be in good shape and they're going to graduate. So there are success stories. There are paths there, but you have to work really hard on yourself, and don't be discouraged if you don't get through the first step. Dr. Arabi and I will tell you that all of us had all these setbacks in our career, and you think the sky is falling, and then that man yattaqillah yaj'al lahu makhraja warzuqhu min haythu la yahtasib. Well, Allah will find you ways. There will be ways that other doors will open, and maybe that's the best for you. Maybe it's best for you to do a residency in the region, and then later on do the independent residency, and then find your way to do the alternate pathway. Or there's several ways to do this, so I would not be so hung up on only one way of doing things. There's multiple ways to do this. So anyway, so that's my advice. Do your job, do your best, and let everything else take care of itself. Control what you can control.
All right. Well, thank you so much. We just have the last question. We know how
You
hectic
said the
IR.
last one was the last question, but it's fine. You can have another
No,
one.
this is not
The
a
last question. Okay.
the last question. All right.
Yeah.
So we know how hectic IR can get some days. So what's your go-to drink before a long shift?
Mhm.
That is the
What
question.
is
What is your go-to
how
drink?
go to drink
Yeah,
after a long
before,
shift? Oh, go to drink
after
after
and
a long
before. Let's
shift.
do both. After and before.
I mean, coffee in the morning, but I'm not a huge coffee drinker. Otherwise, I hydrate. Just water.
Just
I
water.
I just what you have to hydrate. Yes. So it's very important, especially in our age. So hydration is important. So do I get a little bit of a late coffee in the afternoon? Yeah, sure. Tea at night. I only drink tea usually when I go back home. Back home meaning, it's Jordan, Palestine, or the Gulf region when I'm visiting. That's when seems like that's where things happen. At home, I just don't do it as much. But yeah, after work, I just hydrate. Take care of your body. It's that's something that since you mentioned hard work, I'll just add a few more things here. That interventional radiology, if you're doing a procedural specialty, we wear lead all day, and you have to on your feet the whole day. There's some, and this is not unique to us, of course, some other specialties, interventional cardiology, GI, some of them, surgery and such. You're on your feet a lot. You're in your body in tough positions. So always important to learn ergonomics, learn exactly how to stand and all that stuff, and how to take care of your body and to stretch before the procedure, and then to work out and be healthy and eat healthy and hydrate and all this. These are all very important aspects that I think when you're young, you don't think about them. As you get older, you have to think about them. I don't think it's it's something that should discourage anybody from going into the specialty, because if you like what you do, you'll enjoy it, and it's the best specialty in the world. I love it. I think I would not replace it with anybody else. I'm not sure I've seen many people in our specialty who have any regrets about it, because they love what they do and they love the specialty. So, and it's a fun group of people to hang out with, and you have to kind of think, who do I want to hang out with the most? And a lot of times it's the IR and the whole field. It just looks, it's a fun group that is that care about patients. So that should not, so the physical things and the physical tolls should not detract people from going into the specialty. It's not unique to us, but there are steps you have to take care of your body to be able to have longevity in the procedure, in your field.
All right. Well, thank you so much for being with us today. Now, you know that this interview, we're gonna post this interview mainly on YouTube and also Instagram, and that's fine with you, of course.
That's fine. Yes, not on TikTok.
No, not on TikTok, don't worry.
I'm just kidding. I don't care. Yeah.
Okay, fine. All right, so that was really insightful. Thank you so much for being with us today. It's a pleasure and an honor to be able to take advice and know more about IR from you. And I'm sure a lot of students will find your perspective incredibly helpful as they explore IR. And again, it's been a pleasure having you today. And I think that you and other doctors like Dr. Arabi and all the remaining doctors that we're going to have are going to be the main motivation to why students will get into IR. So I, as a person, didn't know much about IR until this interest group opened, and then I started researching and seeing what IR is, and like it's an amazing specialty. The way that we can do things without, because I was always very interested in surgery. So the way that we can do minimally invasive procedures and treatments without the need of cutting a person open is really like a miracle, like something like, yeah,
Mm.
I don't know
I'm
how to
glad you
explain.
feel yeah, I'm glad you feel this way, and I think it's an amazing specialty that when people learn about it, they open their eyes, and that's why I have a lot of interest, and it's, but once it started, it's becoming immediately one of the most competitive specialties, which is great to see, and it's great to see many of you who are interested, who are seeing that and taking the initiative. So thank you for having me, and yeah, I'm always here for any advice to anybody.
Thank you
Good
so
luck.
much. Thank you.
Thank you, Doctor.
Thank you so
One,
much,
one last
Doctor.
thing about the rotations, because you
Mhm.
said one advice is being a good doctor. This is the most true thing ever, because among our medical community, there's this notion, well, I don't have to attend that rotation or do much about it. I think it's really important, صراحة, to get back to it. Thank you really for that advice and
Yeah, I mean,
everything else.
I can tell you that I mean, not to be generational and all this thing, but I mean, we are in and not just this generation, like everybody, all of us, even we're getting older, we're in a phase that you just look for the quick wins, and they just like the easiest way to get things done. And there's nothing that beats the correct way of doing things, the correct process. And you see people focus on the goals and how to attain it with any way possible without having to do the hard work to get there. So I'm glad it resonates. Make sure to share it with your colleagues that the importance of it, and not just even if they don't watch the video or all that stuff. That's not the thing. But as you all become senior students and as you become interns and residents, always instill that in your in the newer people that coming behind you, to just make sure that there's focus on this, and it's important how to become a good doctor, to pay attention to all the details and give your all the time. Don't take breaks.
Inshallah. Then.
All right.
All right. Thank you so much, Doctor.
Thank you so much.
Thank